pericardial effusion and cardiac tamponade. Cardiac tamponade is the compression of the heart as a result of fluid within the pericardial sac. It is usually caused by blunt or penetrating trauma to the chest. A penetrating wound of the heart is associated with the high mortality rate. Cardiac tamponade also may follow diagnostic cardiac catheterization, angiographic procedures, and pacemaker insertion, which can produce perforations of the heart and great vessels. Pericardial effusion with fluid compressing the heart also may develop from metastasis to the pericardium from malignant tumors of the breast, lung, and mediastinum, and may occur with lymphomas and leukemias, renal failure, TB, and high dose radiation to the chest. Cardiac tamponade is pericardial effusion. Pathophysiology. Pericardial effusion refers to the accumulation of fluid in the pericardial sac. This occurrence may accompany pericarditis, advanced heart failure, metastatic carcinoma, cardiac surgery, trauma, or non-traumatic hemorrhage. Normally, the pericardial sac contains less than 50 ml of fluid, which is needed to decrease friction for the beating heart. An increase in pericardial fluid raises the pressure within the pericardial sac and compresses the heart. This has the following effects. Number 1. Increased right and left ventricular end diastolic pressure. Number 2. Decreased venous return. Number 3. Inability of the ventricles to distend adequately and to fill. Pericardial fluid may accumulate slowly without causing noticeable symptoms. A rapidly developing effusion, however, can stretch the pericardium to its maximum size and, because of increased pericardial pressure, reduce venous return to the heart and decrease CO2. This resulting is cardiac tamponade, compression of the heart. Clinical manifestation. The patient may complain of a feeling of fullness within the chest or may have substernal or ill-defined pain. The feeling of pressure in the chest may result from stretching of the pericardial sac. Because of increased pressure within the pericardium, venous pressure tends to rise as evidenced by engorged neck veins. Other signs include shortness of breath and a drop and fluctuation in blood pressure. Systolic blood pressure that is detected during exhalation but not heard with inhalation is called pulsus paradoxus. PULSUS, pulsus paradoxus, PARADOXUS, pulsus paradoxus. Systolic pressure detected during exhalation but not heard with inhalation. This is called pulsus paradoxus. The difference in systolic pressure between the point that is heard during exhalation and the point that it is heard during inhalation is measured. Pulsus paradoxus exceeding 10 mmHg is abnormal. The cardinal signs of cardiac tamponade are falling systolic blood pressure, narrowing pulse pressure, rising venous pressure, increased jugular venous distension, and distant muffled heart sounds. Assessment and diagnostic findings. Pericardial effusion is detected by percussing the chest and noticing an extension of flatness across the anterior aspect of the chest. An echocardiogram may be performed to confirm the diagnosis. The clinical signs, symptoms, and chest X-ray findings are usually sufficient to diagnose pericardial effusion. Medical management. If cardiac function becomes seriously impaired, pericardiocentesis, puncture of the pericardial sac to aspirate pericardial fluid, is performed to remove fluid from the pericardial sac. The major goal is to prevent cardiac tamponade, which restricts normal heart action. During the procedure, patient is monitored by ECG and hemodynamic pressure measurements. Emergency resuscitate equipment should be readily available. The head of the bed is elevated to 45 to 60 degrees, placing the heart in proximity to the chest wall so that the needle can be inserted into the pericardial sac more easily. If a peripheral intravenous device is not already in place, once it inserted and a slow intravenous infusion is started in case it becomes necessary to administer emergency medications or blood products. The pericardial aspiration needle is attached to a 50 ml syringe by a three-way stopcock. Several possible sites are used for pericardial aspiration. The needle may be inserted in the angle between the left costal margin and the xiphoid, near the cardiac apex, at the fifth and sixth intercostal space at the left sternal margin, or on the right sternal margin of the fourth intercostal space. The needle is advanced slowly until it has entered the epicardium and fluid is obtained. The ECG can help determine when the needle has contacted the epicardium. The cable of the pericardial lead is attached to the aspirating needle with alligator clamps. Contact with the epicardium is seen by ST segment elevation on the ECG. During the procedure, drainage fluid must be checked for clotting. Although not entirely accurate, the guideline is that pericardial fluid blood does not clot readily, whereas blood obtained from inadvertent puncture of one of the heart chambers does clot. A resulting fall in central venous pressure and an associated rise in blood pressure after withdrawal of pericardial fluid indicate that the cardiac tamponade has been relieved. The patient almost always feel immediate relief. If there is substantial amount of pericardial fluid, a small catheter may be left in place to drain recurrent accumulation of blood or fluid. Pericardial fluid is sent to the laboratory for examination for tumor cells, bacterial culture, chemical and serologic analysis, and differential blood cell count. Complications of pericardiocentesis include ventricular or coronary artery puncture, dysarrhythmias, pleural laceration, gastric puncture, and myocardial trauma. After pericardiocentesis, the patient heart rhythm, blood pressure, venous pressure, and heart sounds are monitored to detect any possible recurrence of cardiac tamponade. If it recurs, repeated aspiration is necessary. Cardiac tamponade may require treatment by open pericardial drainage, pericardiodectomy. The patient is ideally in an intensive care unit. Pericardiotomy. Recurrent pericardial effusions, usually associated with neoplastic diseases, may be treated by pericardiotomy, pericardial window. The patient receives a general anesthetic, but cardiopulmonary bypass is seldom necessary. A portion of the pericardium is excised to permit pericardial fluid to drain into the lymphatic system. Uncommonly, catheters are placed between the pericardium and the abdominal cavity to drain the pericardial fluid. Thank you.